endoscopy. So thanks to everything I enjoyed last year in St. Petersburg, and very much live demonstration as well as so many lectures. I have learned a lot. In addition to that, I have never experienced working on the frozen liver. First time last year. Very good chance for me. In addition to that, at night I enjoyed the ballet in Mariinsky Theater. Anyway, so thank you so much last year. So let's go back to the cause of my presentation. How about the cause of death in Japan? You know, the male fifth reading of cause of death, pancreatic cancer. Regarding the female, the third reading. And both, in general, the fourth reading, cause of death. And you know, not only the incident rate, but also the mortality rate. So miserable in this pancreatic cancer. At that time, as you can see, so minimum stage 1 shows a better prognosis of the 5 years survival. Now is more than 70 to 80%. However, you know, the stage 4, so less than 10%, around 5%, so not so good. That's why, so we have to overcome this pancreatic duct other than carcinoma, PDAC. So, an answered question, what's the role of the endoscopy in this pancreatic biliary endoscopy in this field? One is the traditional ERCP, and the other is the EUS, endoscopic ultrasound. So let's look onto the diagnosis and therapy. Firstly is diagnosis. So our strategy, my strategy for the diagnosis of PDAC using endoscopy, first, detection of small and early pancreatic ductal cancer. And the other is the far advanced stage cases, we have to do precision medicine. Here you can see a Japanese guideline 2016. Maybe this end of this year we can change the revised version, publish. Now I'm ongoing, the last stage. And in this flowchart, you know, the endoscopic, so EUS and the ERCP can play any role of this flowchart. So regarding EUS, basically, so we can see a precise region and observed through the GI tract. Very useful modality. So 2 years back, we published a paper about the usefulness of EUS in pancreatic cancer in this Lancet. And the US can make it possible to detect even small pancreatic cancer for the good prognosis. Let's see a case. The transabdominal ultrasound shows only dilated PD, but cannot detect any lesion by ultrasound. That US can detect only 1 cm small hypoechoic mass. Finally, could reject the pancreatic cancer. Another one is this is only detection the cyst by a radiologist. Here, we check it only by EUS. You can see, of course, you can see easily detect cystic region, and next to cystic region, we can see hypoechoic mass. that's why. So this region is pancreatic cancer, and this cystic region is a retention cyst. So very reasonable the imaging by using US. How is the detectability of a PDAC by US? Comparing the CT or MRCP, the US is relatively similar, non-inferior. However, looking at the small region, the US is much better than a CT or MRI because very precise, very magnifying imaging by GI tract by US. So looking at the imaging enhanced endoscopy in this in the GI tract field, you know, the NBI, iodine spray make it possible to detect the lesion easily, even in small region. As well, in this field, in the pancreatic ductal cancer, we can use the Doppler tissue harmonic and contrast harmonic imaging and even elastography. Of this modality, I think contrast harmonic imaging is much better. As you can see, using 3-generation sonazoid contrast agent, intravenous agent, we can easily detect a lesion. As you can see, here is a mass, fundamental image, and you can see contrast enhanced image. The bubble or contrast enhanced bubble flows into the region. So we can easily detect, and so we can easily suspect this region going to be a NET, neuroendocrine tumor. On the other hand, this is a mass, slightly broke and so very dark, I'm sorry. Here is a vessel, but around the vessel, the mass, the hypoechoic region, that's why, so we guess this region suspected PDAC. So only by the contrast agent we can easily detect, or we can easily do a differential diagnosis. However, you know which one is really pancreatic ductal cancer? Sometimes very difficult only by imaging. The pancreatic ductal cancer only this. Others, chronic pancreatitis, AIP, or a malignant reformer or NET. That's why, so elsewhere, around the 5% non-pancreatic ductal cancers were rejected as a cancer a year. So what is the diagnosis? 32 years old, female, 64 years old, male. Looks very embedded to the vessel. So later we answered this diagnosis. So for the purpose of the historical evidence, USFNA is one of options in this field. So as you can see, even this kind of lesion, small region, we can easily do USFNA by using Doppler mode to avoid the intervening blood vessel. Finally, to and fro, back and forth, and a needle using just 22 gauge needle. You can see a very nicely histological specimen. So in our unit, we published many years ago, the accuracy is of FNA is 93%. Now it's a more nearly 95%. Very nice modality. How is this CAT scan? We suspected normal, almost normal, but this area, atrophic area, pteropancreas. So looking at this area by US, this is a normal pancreas or slightly the chronic pancreatitis. And here, the tail of the pancreas, we can see easily mass. That's why we can detect this region, look the mass, but so we don't know this is some non-pancreatic cancer or others. Finally, we confirmed this USFN showed adenocarcinoma, and the rejected specimen shows really invasive adenocarcinoma, small one. It is good for the patient to avoid the unnecessary the surgical surgery or do real necessary surgery. How is this case? The low density area and the liver metastasis are large, and the pancreatic dilation. I guess I also guess conventional, the common pancreatic cancer. However, the USFN specimen shows small and rounded hyperchromatin. The malignant cell shows chromogranin plus, keratogranin plus, finally neck. That's why. So we have to change the strategy of for this patient. That's why. So we need historical evidence, right? And in particular, in some cases, the pancreatic cancer shows extrapancreatic spreading, like this, very peripheral origin, and they cannot easily detect or diagnosis, like this. However, using US surrounding area of the SMA or vessel, hypoechoic area, you can see around here, hypoechoic and vessel here. To avoid the intervening blood vessel, we can obtain the tissue. Finally, in this case, we can show the invasive adenocarcinoma, and then we can do chemotherapy after this. So, by the way, so this is undetectable PDAC. You can see 32 years old, 64 years old. Cancer, non-cancer, or non-cancer, or cancer. This is an answer. This is a real pancreatic ductal cancer, 32 years old, female. However, this is looks cancer embedded to the SMA or peripheral, but ARP, just ARP. The CA or CA19A normal and only epigastric pain. So we need like a historical evidence, not only the imaging. And but however, you know that what we can do for the carcinoma in situ. Carcinoma in situ usually not so doesn't show the mass, solid mass. That's why. So if possible, we want to detect dysplasia CIS, which doesn't show the mass. It is so-called early stage. At that time, the USFNA is not effective. So at that time, so no choice. Back to the 20 years ago, 30 years ago, we used to use ERCP for diagnosis of the pancreatic cancer, the cytology or biopsy. So let's see, MRCP shows stricture or dilation of the PD, but no mass by US. That's why so we perform brushing cytology around here, stricture side, and we could get malignant cell. So go to surgery, and finally only a 1 cm small PDAC, invasive but invasive. Invasive means not so good prognosis. Even 1 cm. Another case you can see here, and that only dilation by MRCP, and it shows a relatively hypoechoic region in the PD. That's why, no mass, intraductal growth. That's why we perform the ERCP and the brushing cytology, and we can get malignant cells, and finally, go to surgery, and we can detect. Finally, the reticulated specimen shows a carcinoma in situ only 5 millimeter in diameter here. Real carcinoma in situ. I guess good prognosis, no recurrence. And this is only, this is like a wedge, atrophic area, and slightly dilation of the PD by CAT scan. And even show the no mass, only a narrow area of the PD. And also here, the brushing cytology showed a malignant cell as well. And finally, we can get carcinoma in situ only 2 millimeter in diameter. Of course, at this early stage, patient usually no die. So, but for the advanced stage cases, we need precision medicine, not only surgeon. So now we can have a lot of molecular targeted drugs and companion diagnostic agent using a next generation the system and even genetic panel. So recently, you can see like MSI, microsatellite instability high, or something this kind of good companion marker. So this is English version by Science. The adenocarcinoma pancreatic cancer here, not so many, around less than 5% still. But in near future, we can, of course, we or somebody can detect, can develop this kind of new marker, so we can treat the patient even at a far advanced age. MSI high. It depends on the MSI high or not. We can choose treatment method like this. So finally, we will talk on the therapy a little bit. So diagnostic endoscopy and the therapeutic endoscopy in PDAX, including celiac nerve block or drainage by ERCP or US nowadays, and the ablation for the pancreatic duct cancer. I think it may be brave procedure, but it's not sure it's effective or not. And the gastroenterostomy, last year I presented. And I'd like to show only drainage. You know that nowadays, biliary drainage includes percutaneous transhepatic and endoscopic transpapillary drainage, and another third drainage technique, US-guided transmural biliary drainage like this. So this is a new drainage technique and sometimes very useful. For example, in the USPD, there are two methods. One is transgastric intrahepatic bile duct drainage, or transduodenal or extrahepatic bile duct drainage. And it shows very nicely high technical and high clinical success rate only in high volume center. But in Japan, very year by year, so very distributed this procedure and in any area. In particular, limited in the pancreatic cancer, head of pancreatic cancer, sometimes it shows gastric outlet obstruction. In such cases, we cannot do ERCP or so go to straightly the PTBD. But so not good for the patient. For the minimum invasive treatment is ESBD is one of option, and one is a hepatocogastro, or here is antegrade stenting. There we can use two stenting technique, and even both antegrade stenting and hepatocogastro stenting. I'd like to show you case from stomach. In this case, patient gastric outlet obstruction cases through the stomach, the dilated bile duct was punctured and the contrast agent injection and very nicely cholangiography and using guide wire structure here, upper bile duct side. And once the guide wire across the papilla and firstly here, antegrade stenting. For the physiological bile flow, antegrade stenting is much better. Here you can see. And then to do reintervention later or for sure if in case of acute obstruction or something dysfunction of the antegrade stenting, another stent was placed across the stomach and the bile duct. This is a common technique in our unit in patient with a gastric outlet obstruction. And patient go back to the home. So nowadays, another the dedicated the therapeutic lumen opposing metal stent emerging, like this lumen to lumen approach, and there's a cautery dilator here, cautery enhanced the tip of the delivery system, and we can easily do USPD choledochodylostomy using this modality. And as you can see from the jejunum, a very dilated common bile duct. And the puncture is very, very easy, and once place the guide wire, and like ERCP, after the dilation of the choledochodylostomy site, and using cautery enhanced tip equipped hot axials, and got the bile duct side distal flange open, and then duodenal side open. So immediately after placement of this the hot axials, the no bile leak because of fully covered, and the length of the two flanges is only 1 cm. So we published a paper last year. This is a very nice outcome. Maybe in near future, so we can use easily this procedure. And another paper, the last slide, stent placement, the comparative study have just published from the Love Hose group last year, ERCP versus US BD. In pancreatic cancer. It shows USBD may be one of option from the beginning for the treatment of pancreatic cancer obstruction. This is one of promising data, I guess. Anyway, ladies and gentlemen, in my conclusion, endoscopy plays an important role of diagnosis of PDAC. And sampling obtained from endoscopy may contribute precision medicine, not only the conventional diagnosis, but also precision medicine. And finally, USBD may be the first line drainage for PDAC. Thank you for your kind attention. Thank you.
Большое спасибо, Итои.